Good morning, everyone, and good morning, everyone online. So I'm Kelly Branch, and I have the honor of introducing my former mentor, now colleague, Jeff Probstfield. And Jeff is going to be talking to us about his life as a clinical trialist. He started out and actually got his undergraduate here at Pacific Lutheran University, and actually was the Alumni of the Year for PLU, and that was a great celebration of you. Also went to Marquette Medical School, and then the University of Washington, and then University of Minnesota for graduate school, and was at Hennepin County for residency, and then trained in clinical pharmacology. Jeff has really been instrumental in so many clinical trials over the past number of decades. He has over 300 publications. And I did ask him at one point, I said, how many papers do you have that are in JAMA, New England Journal, Lancet? And he said, honestly, I don't know. I can tell you exactly how many I have of those. So very, very impactful.
It's over 100.
It's over 100. It's over 100. So I'm not sure that everybody else in this room is even close. So it's a remarkable feat. A lot of this is from our colleague Salim Youssef at Population Health Research Institute in Hamilton, McMaster University. And so it's been my pleasure to work with Jeff all of these years, first as a mentee and now as a colleague. And so Jeff is going to tell us about the life of an Itinerant clinical trialist, my life in alphabet soup. Jeff.
Thank you, Kelly. And I've changed the goals this year. The first goal is to remain conscious through the whole talk. Oh, I thought I had it on. Now we have it on, sorry. We had a number of projects that were extremely good clinical trials. I don't know if anybody ever submitted them, but I remember a couple of them, one that Creighton, Don, and David did, that were just absolutely stunningly wonderful. And as far as I'm concerned, they could have been refined and submitted. So randomization is not used in the database, and that is key one. Randomization is not used. Prospective approach is not used. You have to assume that there is bias. There may be selection bias or maybe a number of other sources of bias, which are just absolutely impossible to control. So limitations, what can be done in terms of databases? Well, all kinds of statistical adjustments have been proposed. For my money, at the end of the day, if you're going to do all those, what you're doing is modeling. You're not really investigating data, you're modeling data. So time zero is not usually used. All patients, or do you use a random sample of whatever you're looking at? and it's an inadequate test for a new therapy, in my view. So the clinical trials at the Institute were not used very much until after this sort of seminal article was written by Donald Fredrickson. Some of you may remember that he was the director of the whole of the NIH. At one point, he was director of NHLBI for a while. And his points in that trial were very interesting. He said the trial needs to be done. So you have a question that needs to be unambiguously and appropriately addressed. The trial architecture has to be valid. You have to use inclusion exclusion criteria so it's not impossible for you to recruit. You may know that a number of trials will look at the exclusion patients, and then at the end of the 2 or 3 months, they look at them and see, do we have one or several elements that are keeping us from putting patients in the trial, and they really don't make any difference. So we should change the inclusion exclusion criteria. The trial protocol is feasible. In other words, that you can actually do it. And there can be modifications along the way because it becomes apparent that you can't do the trial the way you set it up. And then the trial administration is effective. Well, this is the first trial I crossed swords with. It was called the Lipid Research Clinical Trial, the LRC. And that trial, we were sort of limited in the medication we could use. The only thing we had available to us at the time was cholestyramine for lowering cholesterol. And the question we were trying to address was, could you lower cholesterol and modify coronary heart disease? Well, the sample size, I think, originally was about 4,000. We put 3,810 in. And the primary endpoint was coronary heart disease, death, and a non-fatal MI. Well, this Kaplan-Meier looked very impressive, but at the end of the day, there were some problems with it. But it was thought to be the first trial that looked at, that would you'd be able to say that cholesterol lowering affected coronary heart disease. So this shows you the raw data. Now, when you only have 32 events difference between the two groups, I'm nervous about that. In my view, that data is a bit fragile. Well, at the end of the day, it gave you a p-value that was only a one-sided 0.05. And there was a very prominent member of the biostatistical group here, and Ed Davis, who was the director of the coordinating center, went around the world debating whether or not the LRC actually you say, why in the world would you ever do that? Well, it turns out that the terminal 30 centimeters of the ileum is where most of the bile acids are reabsorbed. And so that is a main way of the excretion of cholesterol. So Henry devised this trial. I believe there were 5 centers involved. And the original sample size was 1,000. You can see we only got 838 patients. And the only reason they stopped there is because they had been recruiting for 8 years, and the NIH said, we're not giving you any more money. The primary outcome was fatal and non-fatal CHD. And you can see at the end of the day, they didn't quite reach statistical benediction. Okay. But on the way along, they saw that people who had an EF below 50 might have a different response. Now, this makes me nervous. You're looking at a continuous variable, and that's a problem. So at the end of the day, it turned out that 24 versus 39 had patients that that would have satisfied this criteria, and there was a p-value of 0.021. Okay, Well, the New England Journal actually published it this way. Now, the correct way of doing this is after you identify this issue, you set up the hypothesis and look at the endpoints afterwards. And if you had done that, you would only have had 18 versus 22. And obviously, you don't have to do any statistics to know that that does not reach the criteria. My first job when I went to the NIH was to look after systolic hypertension in the elderly program, or SHEP. And I was blessed with that because when I went to the institute, I didn't know anything more about hypertension than most of you sitting in the room. But I was meant to lead a clinical trial that had 17 centers in it. And many of these had been in a previous blood pressure trial, and they were all very eager to look at this. Now, this was really the first substantial trial that looked at the reduction of systolic hypertension. Practically all of the previous ones had looked at just the reduction in diastolic hypertension. And the problem with many of those was that they didn't have enough women in them. So there was a claim that reducing blood pressure didn't affect the outcomes in women, which is, on face value absurd. So we were meant to have 4,800 patients in this trial. We got to 4,736. And the primary endpoint was fatal and non-fatal stroke. Well, you can see here we got a very nice 36% reduction in stroke, which had a hugely significant p-value. And this was the first trial in which you could actually show that there was a reduction in CHD endpoints as well. So a very important landmark. Aim High. Aim High was a trial that was an investigator-initiated proposal. And many of you will remember Greg Brown, one of our colleagues. He and Bill Bowden and the guy from the drug company that sold extended release niacin were the prime movers in putting this together. And you can see what we were trying to do was raise HDL to see if that would reduce coronary heart disease. Well, disappointingly, you can see that the Kaplan-Meier shows that the two lines are superimposable, basically. Now, there are some caveats here. The mean triglyceride value of the people that got into the trial was 168. And some of you who are familiar with treating lipid disorders will know that no self-respecting lipidologist would treat a patient who had triglycerides of 168 with nicotinic acid. So we knew that we found that only afterwards. Note to file, you should have done a pilot study ahead of time to find out exactly what those levels would have been before you got into it. HDL levels were about 35 in men, slightly higher in women, and you only got about a 4 or 5 milligram per deciliter increase in HDL. So one might say, did you really test the hypothesis? Now, for those of you who are familiar with HDL physiology, you'll know that there's lots of questions that have been raised. There are some fragments of HDL that are thought actually to be injurious, not protective. And so the HDL story is far from completely illuminated. This is the biggest hypertension trial that has been done. ALLHAT had 44,000 patients in it. It also had a lipid-lowering trial in it, but we'll not discuss that today. The main comparison in ALLHAT was a comparison of amlodipine, doxazosin, and lisinopril against chlorthalidone. Chlorthalidone had already been shown to improve the outcomes for blood pressure. And so 44,000 patients in it, you can see that the reductions in blood pressure were relatively comparable for lisinopril and amlodipine. Doxazosin was terminated very early because there was a substantial increase in heart failure. So that arm was discontinued. Now, the primary endpoint leaves a lot to be desired. If you were looking for a positive outcome, they're basically superimposable, the three arms. The primary endpoint being fatal and non-fatal CHD. Little problem. The frequency of heart failure in the three arms is really quite different. Now, caution. This does not mean that either lisinopril or amlodipine cause heart failure. What this graph shows you is that chlorthalidone is more effective in preventing heart failure than the other two agents, at least in the protocol that we did. The studies of left ventricular dysfunction. My esteemed colleague with a huge shock of black hair had just come from Oxford. He had been a Rhodes Scholar, and he came very specifically to look at the issue of ACE inhibitors and how they might affect heart failure. And as you can see here, this is a solved treatment trial, and these patients all had an EF below 35, and they were in addition symptomatic. I think we were meant to have about 2,500. You can see we very nicely exceeded that. And the primary endpoint was all-cause mortality. And you can see we very nicely achieved that with about a 16% reduction in the primary endpoint, highly statistically significant. Now, this is a forest plot or a pedogram or a branch diagram. And what I want to caution you is look at the point estimate at the very bottom of the chart. Each one of those individual estimations are to be compared with that. You don't compare the issue of the different levels of sodium, for instance. You don't compare those one against the other. You compare each one of those with the point estimate, and by visual inspection, you can see that the confidence intervals of those, all of them overlap. Not only the confidence intervals. What happened here? Did I do this? So they not only overlap there. Oh, I have to go. Sorry. They not only overlap the confidence intervals of the point estimate, many of them overlap the point estimate itself. So by visual inspection, you can say that none of those subgroups are statistically significant. Now, there are formal ways for testing that, but by visual inspection on this branch diagram or pedogram, you can say none of these subgroups are statistically significant. The Salt Preserve trial was a very interesting trial. These patients had EFs below 35, but allegedly they were asymptomatic. And we put over 4,000 patients in this trial. And again, the primary endpoint was all-cause mortality. Interestingly enough, we got out to about 48 months of total observation. You can see the numbers out there are relatively small in terms of number of patients that were out there, and it was not statistically significant. Salim and I literally begged the DSMB to let us go at least another six months, if not another year, and we actually had the money to do it. And the DSMB said, this is the way the protocol was set up, and we're going to have you terminate the trial. So this would be considered a null result. But my dear friend, always inventive, said, we're going to look at the 12-year follow-up of these two trials. Now, obviously, in the meantime, you have no idea what these patients are taking. You don't know whether they're on ACE inhibitors or diuretics or whatever. But what you can ascertain is whether they're alive or dead, and in many instances, you can identify what the cause of death is. So the short story is, in the treatment trial, you can see that at the end of the day, both of these maintain a level of statistical significance for all-cause mortality and cardiovascular death. So this was the one that we were really interested in. We were interested in the preserved trial. And in actual fact, at the end of the day, there were very nice reductions at 12 years for this trial as well. So would you treat these patients on the basis of this? Well, there have been several trials after this looking at preserved ejection fraction to see if we could get a reduction. And some of that is to be discussed later. But on the basis of this, people would say it's interesting. We might consider it. When we did the SOLVE trial, Salim saw that probably the cardiovascular, that is CHD, or CVD death, MI, and stroke might very well be reduced with the treatment of by ACE inhibitor. The original sample size was 5,000. Very interestingly, the DSMB reported to us that the event rate was low, so it was hiked to 7,000. And they said, again, the event rate is low, so it was hiked to 9,000. You can see we eventually put 9,267 participants in this trial. The interesting thing is it was a patchwork of funding. Eventually, at the end of the day, 14 different agencies helped us fund this, but you may remember from HOPE, a stunning result, 22% reduction in risk with a highly significant p-value. Now, this is a diagram you'll not see any place in any publication, but it happened to be in something that the investigators got, and I thought it was very interesting to help us understand about monitoring, what the DSMB looks at. You can see that at the beginning, the Z value that they're trying to look at in terms of monitoring guidelines is extreme. It's 4. And you can also see that the DSMB meets at intervals of about a year. That's very common behavior for a DSMB. And you can see there's a very nice progression. So in November of 1997, they decided that they would still wait another year. But you can see this is also when the monitoring boundary becomes less extreme. Well, lo and behold, the huge sample size caught up with it, and all of a sudden we've got a Z value that's 4.31. And standard DSMB behavior is to look again 3 or 4 months later and to see if that was by chance alone or whether you really have something that's there. And again, it's there. It's even more extreme. And the 4.76 is the value for Z, which was obtained when all the data was cleaned up. So it isn't that, additional time was given. It was just that data was completely cleaned up. So then that foray into the treatment of heart failure with an ARB, and this is the CHARM trial, which had 3 components. The CHARM alternative was those people who allegedly could not take ACE inhibitors. So that was one. The CHARM added, you added the ACE inhibitor or the ARB on top of everything else. And the CHARM preserved was for those people who had, would have HFpEF or an EF that was somewhat higher. So we're going to talk about the alternative, the people who couldn't take an ACE inhibitor, could take an ARB. They got a very nice 23% reduction in risk, and you can see that's highly statistically significant. Very interestingly, the CHARM preserved trial didn't quite make it. And you can see we have not only the raw value, but we also have an adjusted value. Well, one of the investigators in the audience had the temerity to ask, what did you do in terms of the adjustment? Well, we had 32 variables in the adjusted value. There was an explosion of laughter in the room, and they said, we're going to go back and add a few more factors to see if we can get the statistically significant p-value. And the investigator said almost in unison, don't bother. And nobody presented this with the adjusted value being the important value that you were talking about. The ACCORD trial was a very interesting trial. The most expensive trial that I was involved in long-term cost at the end of the day probably close to $400 million. And the test here was to see if lowering the HbA1c to about 6 compared to what you might get with more standard care, usually about 7.5, to see if that difference in HbA1c would give you a reduction in coronary heart disease endpoints. Now, you say, why didn't we do just a 2x2x2? Okay, and randomize everybody in terms of the blood pressure and the lipid trial as well. Well, there was cautions given because previous trials that had three-way factorial had been problematic. So we were cautioned about that. And we also knew that if you did sample size calculations, you didn't need the full 10,000 patients to look at the blood pressure question, nor at the lipid question. So you can see this, we ended up with a double 2x2 partial factorial design, but the full 10,000 patients in the glucose question. Well, something happened on the way to the farm. The investigators were called together early. We had no idea what we were being called together for, but all of a sudden it turned out that those people for the glycemia question not only did have no improvement, there was actually harm. And so the glycemia question was terminated early. The blood pressure and lipid evaluations went forward. The blood pressure question was 140 versus 120. And we found that there wasn't any reduction in the heart disease endpoint. But very interestingly, although the numbers are not terribly robust, you have a clear reduction in stroke that's statistically significant. Now, nobody went around trumpeting the fact that this was the case, but it's clearly there. And me, as a treating physician, I would use this. Now, many of you may know that the SPRINT trial was subsequently done in non-diabetics, looking at the same issue, less than 140 versus less than 120, and showed very, very significant reduction in endpoints. How about the lipid question? We were looking at what would be the effect of clofibrate or afibrate on top of whatever else you were using for lipid lowering to see if that might raise the HDL and give you a value. Well, you have to understand that this was going on at the same time AIM high was, so we didn't have the answer from AIM high. The overall question, we had no reduction in cardiovascular outcomes, but very interestingly, we did standardized retinal examinations that were read by a central laboratory, and you can see those people on fibrate actually did very much better in terms of their long-term retinal examinations than those people who were not. So on target transcend, this is the evaluation of an ARB in terms of the same question that Hope gave us. Now, there were several questions here. We had talosartan versus ramipril in a non-inferiority trial. More about that in a moment. We had talosartan plus ramipril versus ramipril in a superiority trial. And then for those patients who were supposedly not able to take an ACE, we had talosartan versus placebo. Now, interestingly enough, the superiority trial, ramipril and placebo versus talosartan and ramipril, turned out to have a very large number of kidney problems associated with it. So although the results were, I would say, mildly positive, we could not recommend using the two together. In fact, we strongly recommended that they not be used together. So how about and the Transcend trial, for whatever reason, gave us a null result. So how about the telmisartan versus ramipril in the non-inferiority trial? So a couple of words about non-inferiority trial to begin with. You see, these are the displays that you might expect. In a non-inferiority trial, you set up a boundary. You don't want the result to be worse than this. And commonly, this is set up by a committee. It's not set up on statistical basis. In this particular trial, it was set up on a statistical basis using information from HOPE, because we were trying to compare basically the same question as we did in HOPE. Well, the extreme lower shows you what happens if you have a point estimate and the confidence intervals clearly below the boundary. That would suggest that ramipril is better. The one in the middle, where you have the point estimate and then you have 95% confidence intervals, both beyond the bound, both beyond the margin and beyond one, that's really basically a null result. And what you're looking for, hopefully, is a display above, which shows you that you have the point estimate with the 95% confidence intervals clearly above the boundary. So those are the three potential. Obviously, the one other that's not on here is you could have the point estimate and the 95% confidence intervals above one, in which case telmisartan would be clearly better than ramipril. So this is what we got. Very nicely, the primary composite showed that ramipril and telmisartan were basically roughly equivalent. And it didn't make any difference whether you use the composite endpoint that we had in on target, which had a heart failure component added to it, or you use HOPE, the HOPE endpoint, which had MI, stroke, and CVD death. That either way, you had clearly a non-inferiority. Now, if you ask any of the coordinating center directors to do an on-treatment evaluation in most clinical trials, they will laugh at you. They won't even consider it, because they think there's so much potential opportunity for bias. In a non-inferiority trial, you must do an on-treatment analysis. And as you can see here, that even if you do an on-treatment analysis, there's clear evidence of non-inferiority. Okay, how about the rosiglitazone aspect of the DREAM trial? I think most of you are familiar with a factorial design, okay? In this particular trial, where we're looking at the component which was rosiglitazone versus nil. And of course, you have one component which has both of the elements in it. So more about that later. But very interestingly, in this trial, rosiglitazone gave you a 60% reduction in people going from impaired glucose tolerance or impaired fasting glucose to diabetes, a 60% reduction. Now, for those of you who are old enough to remember me giving grand rounds, you'll know that you've heard me say that if you see a trial that has a 50% reduction in risk, you can count those on one hand. And this is the only one that I really remember seeing. Thank you. So at any rate, we were urged to do a trial that had only rosiglitazone in it. And the interesting thing was we got that trial going and we were recruiting socks off. I mean, the recruitment was just off the charts. And all of a sudden the FDA came in and they said, we want you to stop the trial. Well, there were two issues. There was a very badly done meta-analysis which suggested that rosiglitazone might be associated with an increase in heart failure. And the other, perhaps even more important issue was the makers of pioglitazone were hoping to do a trial, and they were hoping to show that pioglitazone was better than rosiglitazone. I don't know how you could do that without doing a direct comparison, but nonetheless. So the FDA killed the trial that I was talking about. Interestingly enough, the FDA came back to us 2 years later and said, is there any possibility you can put that trial together again with rosiglitazone? And Salim and Herzl just laughed at him. So TopCat, a very important trial in which we tried to look at treating HFpEF with a spironolactone. And you can see here, we put in almost 3,500 patients. Actually, the original sample size was 4,000, and the recruitment was so difficult, the primary investigators in the trial said, we'll be happy with 3,500. I cautioned them that that might be a mistake. In actual fact, there was a point where they were trying to do only 3,000. I said, that will really be a mistake. And I got them to go to 3,500 at least. So at any rate, the primary endpoint was CVD death, heart failure, hospitalization, and resuscitated cardiac arrest. And you can see very nicely, there is no, it's 11% reduction. The hospitalization for heart failure, however, was statistically significant. So a very interesting thing happened. There were four countries in the Americas that participated. And then there was 2 countries in Russia and Georgia that participated. And the incidence of cardiovascular events was incredibly different. Now, roughly half of the patients in the trial were from Russia, Georgia, and half of the patients were from the Americas. And you can see, if you look at that, the patients from the Americas, the result in that group is statistically significant. Turn this phone off. And so that examination is statistically significant. And so we went back to look and see what happened in Russia, Georgia. Well, the interesting thing was one of the admission criteria was an elevation of BNP. Practically nobody in Russia, Georgia had an evaluation of BNP. Practically no one. And practically everyone but one in the Americas had an evaluation of BNP. So not only were they symptomatic for heart failure, they had elevations of BNP. And there was some question about how well the questioning for heart failure was done in Russia, Georgia as well. So without bashing them too much, there was a clear difference in the patients that were admitted in Russia, Georgia as compared to the Americas. Published in a separate article, all the cautions were given about it being a subgroup analysis. Flat sugar was a very interesting trial. It was done here at the was initiated here at the University of Washington. And my colleagues, Kevin O'Brien and Earl Hirsch were very much involved in this. And we had a colleague at the University of Oregon, recently died, Matt Riddle, who was also very significantly involved. In fact, he was the one who urged that we used exenatide. Now, you see a display of the gyrations in blood sugar. And it is known that you stimulate the inflammatory protagonists both with the peaks and with the extreme valleys. So what we were trying to do was reduce the modulation, reduce the peaks and the valleys. Primary endpoint was a change in coefficient of variation, and we only had to have 100 patients in the trial. And you can see the first panel shows you the coefficient of variation analysis that we selected to be primary. That was what we selected before the trial began, and you can see it gives you a statistically significant reduction in the variation. Now, the other three panels here are other ways of assessing the coefficient of variation, and all of them were in the same direction. In actual fact, there were two other analyses done, which are not on display here. They showed exactly the same directional issue, only a few of them were statistically significant. But the very interesting thing was, in this short period of time, using this regimen, you got about a 4.75 kilogram reduction in weight, and highly statistically significant from the people who didn't use this approach. Compass, a very interesting trial. Cardiovascular outcomes for people using anticoagulant strategies. And this was stopped early with an extreme z-value of 4.59. And this was for the arm having rivaroxaban and aspirin in it. The rivaroxaban double dose had also a statistically significant value, but the number of side effects with that particular regimen were substantially greater. And you can see the Kaplan-Meier curves here. Rivaroxaban plus aspirin clearly reduced. Rivaroxaban dose was 2.5, aspirin 100 milligrams a day, and that was compared with aspirin 100 milligrams a day. And a very nice reduction in the cardiovascular endpoints. Interestingly enough, we evaluated peripheral vascular disease as well. To my notion, this is the only trial that has been done that shows a clear reduction in peripheral vascular disease outcomes. A number of them have claimed reductions very much smaller, but this one clearly had a nice reduction in peripheral vascular disease outcomes. So bless me, Father, for I have sinned. The prostate cancer prevention trial was one of my dalliances. We looked at finasteride versus placebo, and finasteride is an enzyme inhibitor which prevents the final conversion of testosterone to what is believed to be a variant of testosterone, or a end product of testosterone metabolism, which was associated with the increased risk of cancer. All the patients in the trial were above a certain age, and they had PSA below 3. There were 18,000 patients in this, and the primary endpoint was incident prostate cancer. So you can see a very nice reduction, 25% reduction in prostate cancer. Well, not so fast. The Gleason score tells you about how aggressive, how severe the prostate cancer is. And interestingly enough, you can see all across the bottom panel there, the Gleason scores in patients who were on finasteride were higher. And so if you got prostate cancer, you probably got a more aggressive prostate cancer. Then I was involved in a huge trial, SELECT. This was a selenium and vitamin E, again, a factorial design where we compared vitamin E versus placebo and selenium versus placebo. PSA is less than 4. And the intent here, you put in huge effort to put people that were African-American and of Asian descent. And we actually got about 14% of the whole trial that met those criteria. Huge effort. And this is what we saw. Really not any difference during the observation period of any of the 4. Now, interestingly enough, polyphygal did a sample size calculation so you could compare any one of the boxes. Okay, so you could compare selenium by itself with selenium plus vitamin E, or vitamin E versus selenium. And very interestingly, you can see that none of them during this period show you statistical benediction. Well, result in vitamin E was suspicious enough, so we did passive follow-up. Now, why was this important? Well, at the time, there probably had been 150,000 patients in trials looking at vitamin E for cardiovascular reduction. None of them showing even a whiff. But many cardiologists were continuing to let their patients use vitamin E just to say, oh, they think it helps them and they feel good because they're on something, they think they're doing something. So they could let them continue to do it. Well, maybe not so much. Because you can see here that a vitamin E in the extended follow-up is clearly associated with an increase in prostate cancer. Now, of course, in the last 5 years, we don't know that whether they were on vitamin E or not. So this is again just an incidence of prostate cancer, and that's all you have. So the next 2 slides I'll show you very quickly. Those are the 32 trials that I was in that I'm not talking about today. And some of them are huge, but again, I selected the ones I did for the reasons I gave. Now, again, bless me, Father, for I have sinned. I have 2 other things that I was very much involved in. The Interheart Registry was a very interesting trial in which we did a case control study in 52 countries. The final results session where we got the results, it looked like a meeting of the United Nations that happened in Delhi, and a fantastic end of the registry event. So there were over 29,000 patients in the study, 15,000 patients who had MI, and 14,800 controls. How did we find the controls? Well, they were allegedly visit in either the eye doctor or the dermatology office that were thought to not be at high risk for cardiovascular disease. So height, weight, waist, and hip circumference, a blood sample, and some questionnaires were done. And very interestingly, these 9 risk factors clearly stood out as having an association with either the development or the prevention of cardiovascular disease. So these 4 are associated with 80% of acute myocardial infarction. But you see here, you have obesity and the psychosocial index, which were very clearly associated with the development of cardiovascular disease, which are not in it. But the interesting thing is, if you look at all 9 of these, they account for over 90% of the risk. Now, there was another study called the Emerging Risk Factors, which came out and largely supported the evidence. There were some differences in the 2 studies, but they were largely supportive one of the other. Now, you will not find this in any published paper. And I always find this graph incredibly interesting. It shows you the odds ratio for each one of the 4 risk factors: smoking, diabetes, hypertension, and the ApoB to ApoA1 ratio. Now, if you add smoking, diabetes, and hypertension, it ends up a little bit over 7. But if you look at the composite risk of those 3, 1, 2, 3, it's 13. And if you look at the composite risk, if you have all 4 of those risk factors, it's 42. If you have at obesity, your risk goes up to 68-fold. And if you have all 9, you have a risk of 333-fold. So what this tells you, and the exact numbers may be off, and obviously there are gradations of smoking, gradations of diabetes, and so forth. So it's not all or none, but the interesting thing is it's a multiplicative association. It's not arithmetic. So Kelly and I gave this grand rounds on GCHF. Maybe it's almost 2 years ago now, but you can see We originally were supposed to gather these patients for a heart failure trial. So we collected it, and all of a sudden the drug company said, we're not going to do the trial. They were going to do it in-house. And then they ended up not doing it at all. So we ended up with the largest registry of patients with heart failure and the longest time of follow-up. And you can see what was how the trial was set up. And then there was a sub-study of 4,000 patients, even drilling down further. So there's a very big difference if you look at the countries by income, and this is the World Health Organization definitions. Certainly ischemia is much more prominent in the high-income countries, and perhaps hypertension more prominent in the other countries. And the relationships for death and for hospitalization are basically one is inverse of the other. So after this, some of you may want to become a trialist. I've been blessed to travel to, I think, at least 35 countries. As Kelly mentioned, I have been blessed with 300 publications. I can tell you a very small portion of those I'm the first author on. So how do you do that? Well, first of all, you take a course, and then you identify a good collaborative group. There's still the Timmy group, and there's still the Duke collaborative group. So there are groups around that you can be involved in and perhaps do a trial. And then you take a staff position in the trial, learn how to do the process. So you'll learn how to do recruitment, adherence, retention, and how to do closeout. All of those processes are critical. Then finally, very importantly, volunteer to be on a writing group. You'll not be the first or last author. All the senior physicians or investigators in the group will have those positions, but you need to learn how to do the writing of a final results paper and see how it's pieced together. Identify a sub-study that you can work on. In the LRC, I identified adherence and retention as something that was very important. I spent the rest of my career working on that, and I guess I'm identified as a modestly expert person in that area. If you get a chance, go to the Population Health Research Institute up at McMaster, Salim's group. Or if you're truly blessed, you'll get to go to NHLBI and be in the clinical trials group when I was there for 8 years. I don't have a master's degree from an institution, but I have a master's degree from the School of Hard Knocks, because you learn how to do trials and you learn the trials methodology. Finally, don't be discouraged by a null or negative result. Richard Pito and Rory Collins and Salim wrote a very important paper called that was in Statistics in Medicine, I think, I don't know, early 1970s. And one of the key points in that was ask a good question, get a clear answer. Don't aim for a positive answer or think you might get a negative answer. Get a clear answer. So it's sized properly, the methodology is good, et cetera, et cetera. Oh, some people that I need to say thank you to forever. Salim, my extreme colleague, my important colleague for 40 years. Herzl Gerstein led most of the diabetes research that happened up there. Jackie Bosch was a major domo up there. Nothing moved or got approved or disapproved or whatever without Jackie putting her hands on it. Kevin was my incredibly good colleague from the beginning here, and Kelly and I have worked for 25 years together. Earl Hirsch and Matt Riddle, Matt recently died, were very important in the Flat Sugar Project. Rose worked with me on Interheart and the EpiDream study. Creighton was involved in one of the studies, and he actually identified 200 patients for one of the studies. And Peter Leary and I and Kelly was involved in the same project. Peter had a very interesting I think it's called a P68. And it's your first trial, a single center, and you have a question that you want to address. And Peter identified this question looking at treatment in pulmonary hypertension. And we spent 5 years doing this, and we just recently published a result, have another paper that's gone into for publication. Now, I'd be remiss if I didn't recognize these people also. I had the extreme pleasure and honor of working with Larry Friedman, who was a branch chief, and Kurt Furberg will always tell you he hired me to go to the Institute. The three ladies below were the longest coordinators that we had. They were just fantastic. They knew not only how to do the trials, they knew how to do the finances associated with the trial. And I would be extremely remiss if I didn't mention my incredible colleague, Tom Fleming. Tom, as you may know, is a world-class biostatistician. Very few like him. He's been probably on 300 data and safety monitoring boards, so he knows a little bit about that. Tom wrote me a note a couple of years ago. We had started treating the clinical trials course in 1994 together. He wrote me a note about 3 years ago saying, we've had over 1,000 patients in the course. So if you look at what your legacy is at the end of the day, it's always wonderful to see that you've had an opportunity to pass it on to somebody else. So Tom, my extreme thanks to you. If we taught the course together for the first time, I thought Tom was going to say, Probstfield, get out of here. What he said was, Probstfield, if you think you're going to get out of this, you're badly mistaken. So we taught it together for the next 30 years. And my dear sweet lady that I was married to for almost 56 years, may she rest in peace. She read practically everything I wrote for either a proposal or an application. She was a physical therapist by training. She didn't know all the science, but she knew how to write. And that was very important. I mean, any of you who are submitting proposals, you know that it is very important how you present it. And she would sometimes say, this makes no sense. You need to reorganize this. And of course, she was right. So thank you very much.
So thanks, Jeff. And I'll open this up for any comments or questions to the audience. And I would like to acknowledge one thing in that Jeff is very humble about, but he says, take a class. So Biostatistics 524, right? This is the class. This happened to be my favorite class ever, right? Taught by Tom and Jeff. And this teaches you how to do the clinical trials. That's what he was talking about. At the end of the class, you have a written R01. That's the end point. And then you have to go and defend the R01 with us people kind of critiquing it. But we'll do it kindly. And so you get good feedback, and actually many of those have actually become
but the important R1s. Issue is you have to examine another group. So you have two roles in this. You get to present, but you also have to examine. Absolutely. Very important. So we do these over 3 days. We usually have someplace between 8 and 11 of these, each 2-hour examinations. So it's a very intensive period for the professors.
Not much sleep for the professors. Fareed.
Jeff, that was just fantastic. This reminded me of the fellows lecture you used to give on trials. It was excellent.
The which trial?
Your lecture to the fellows.
Oh, yes.
Yes.
Yes, I did that a few times.
Yes. My question is, can you comment to us transition over time of in your career of trials being sponsored by the NIH versus trials sponsored by industry? Most of the major trials these days are sponsored by industry.
So I was extremely fortunate. I was in a few trials when I was doing my clinical pharmacology fellowship. They were mostly comparing, at the time, clofibrate with cholestyramine or cholestyramine. So those are the trials that were small and they were industry sponsored. My first real trial was the LRC. So, out of the frying pan into the fire immediately. And of course, we had huge trouble with recruitment. It was very difficult. You had to find patients all who had an LDL level above 175. They all had to have a value above 175 on multiple occasions. So recruitment was incredibly difficult. And we struggled to get 3,810 patients in that trial. So the transition for me was almost nothing. I went basically from a few very small trials from industry looking at lipid-lowering agents to the LRC almost directly. And then immediately after the LRC, I went to the Institute.
Okay, one more question. No.
Thank you. I really enjoy your talk. I've always been sort of suspicious about combined endpoints. That
Yeah.
somehow you're trying to pull some
Yes.
weak sisters across the finish
Yes.
line by coupling it to a
Yes.
to a real significant factor. Well, how do you feel about that?
So it's an incredibly important point. What you didn't see was most of the time when we give the results of a trial, we not only give you the composite endpoint, but you give the results on each one of the factors of the composite endpoint. And you can look for consistency. All of those may not reach statistical significance, but hopefully they're all in the same direction. You know, virtually always if you're looking at CHD or stroke or non-fatal MI, they're practically always in the same direction. So yeah, I mean, but you're right. I mean, we have to be very careful about those, and we try to look very carefully to begin with to make sure that we are putting composite endpoints together that make sense. But your point is valid and well taken.
Okay, and with that, we are at time. Thank you, Jeff. Thank you, everyone, for coming, and we will see you at next Grand Rounds.
Did that work?